Occupational therapists specialize in activity analysis, which is something we'll go in depth further with in the following slides. And then we focus on what occupations look like in real life. So what's important to the individual. We either address the impairment or we will modify the task or the environment to facilitate easier completion. So this visual showcases how occupational therapy is a holistic approach. OTs will focus on what matters to you as opposed to what's the matter with you. A holistic approach takes into consideration the whole person. So it's an integrative outlook on therapy to understand the client and look at every factor that may affect their well-being. So some factors that might affect their well-being would be their education and training, their social, cultural, and spiritual beliefs, their finances, their money, their work and occupation, and then their caring relationships. So each person has specific occupations that are unique to them. Occupational therapists specialize in evaluating and treating these occupations, and they're divided into 8 different categories. So the first category would be ADLs, or activities of daily living. And this is kind of the bread and butter of occupational therapy. It includes self-feeding, dressing, bathing, toileting, sexual activity. And then we have IADLs, which are instrumental activities of daily living. This includes the care of others, the care of your pets, driving, financial management, communication, health management, meal preparation, and safety and emergency preparedness. The third category is sleep and rest. So this entails the actual act of resting, as well as sleep preparation and participation. The fourth category is work. So this would be employment interests, employment seeking, job performance, and retirement preparedness. Next, we have education. So this would be formal and informal education participation. The sixth category is play. This is something we see more in the pediatric population, and it includes play exploration and play participation. We have leisure, so leisure exploration and participation. And then we have social participation, which is engaging in activities with the community, the family, and with friends. So as mentioned earlier, OT specialize in activity analysis. So we analyze the different occupations that we just talked about, and then we determine if there's any deficits or limiting factors. So for an example, we might do an activity analysis on a patient completing dishwashing. So is the patient able to wash the dishes independently? If not, what's preventing the person from completing the activity independently? What are the demands of the activity? What are the barriers to performing the activity? What skills are required to complete this activity? How does the environment affect the participation in the activity? And what is the cultural meaning ascribed to the activity? So after the activity analysis is complete, OTs have 5 different approaches to implement change. I've included some examples for each approach that might be relevant to a setting such as Sonata West. So the first approach would be create. So creating a fall prevention class to encourage safe mobility throughout a person's home. Then we have establish or restore, restoring a person's upper extremity motion to facilitate transferring dishes to a dishwasher. We have maintain, maintaining safe access for people with low vision by increasing hallway lighting in their home. We have modify, modifying clutter in a person's home to decrease distractibility or fall risk. And then we have prevent, preventing social isolation by promoting participation in activities. So we talked earlier about how OT is a multidisciplinary approach. We work closely with the client's family, with staff members, and with caregivers. We're often associated with physical therapy and speech therapy, and a lot of people tend to get the 3 of us confused. So this visual just highlights that while we have very similar roles, we are all trained in different aspects to look at different things from the patient. So how is this all relevant to you? So occupational therapists can offer an array of services, all dependent on the patient and how they present or what's important to them. So here I've highlighted some of these general areas that may be specific to an assisted living facility or an independent living facility. And we'll go into depth further in the slides that follow. I do want you to keep in mind that occupational therapy is a very fluid occupation, so some of these concepts may display some overlap. The first concept is aging in place and home modifications. OTs offer assessment of a patient's home environment and then modification of it in order to facilitate their desire to remain in place. Once information is gathered on the patient's daily routines or their habits, we can assist in locating modifications that will aid or increase their safety and independence. Some examples of this service may include providing censored lighting in walkways or entrances to decrease fall risk, providing color contrasted grab bars for a patient's shower or toileting area for increased safety. We can provide emergency response system recommendations, strobe light smoke alarms or flashing doorbell recommendations for patients that may be hard of hearing. We can provide access to community resources. We can provide financial planning so that they can allow themselves to stay in the same environment. And we can organize and provide access for emergency contact information. So in close relation to aging in place, we have the OT's role in fall prevention. Some examples of OT interventions that may reduce the risk of falls would include assessing the environment and removing hazards, such as removing a throw rug in a patient's bathroom. We can provide education to the patients on what fall risks are in their home, increasing their safety awareness. We could also provide them with visual aids. We can provide lighting recommendations. So where does the patient frequent? Are there areas of low lighting in their home? We can restore and maintain the strength, endurance, and balance necessary for mobility. We can provide dressing recommendations. So what type of shoes are safe for ambulation? We can provide assistance with medication management. Which medications may make the patient drowsy? Which medications create a fall risk? Are there times of the day the patient should be taking these medications? We can address the fear of falling, improving patients' confidence with fall risk and ambulation results in a decrease of falls. And then we can provide education and recommendations for adaptive equipment use. The next topic we have is strengthening programs. Oftentimes with the elderly community, increased weakness may inhibit a person's ability to independently complete certain tasks. So we offer strengthening programs that may be specific after identification of a weak muscle or a weak muscle group, or we also offer generalized strengthening programs. So a generalized strengthening program may include functional transfers and gross motor strengthening, such as participation in bed mobility, completing sit-to-stand transfers, participating in functional mobility, and the use of their assistive device. We're also trained in fine motor strengthening programs, which would include therapeutic programs for increasing grip strength or digit strength. We also specialize in handwriting and fine motor coordination programs. We generally will develop an individual home exercise program for a patient, much like seen here in this visual. That's actually one I tend to use with my patients, and then I specialize it based on the individual's abilities. The next service I've highlighted is the OT's role in patients with low vision. So we may assist a patient with low vision by prevention, preventing an accident or injury by improving lighting in low areas of light. We could teach a patient new skills, such as eccentric viewing or visual scanning. We can modify the task or the environment, such as using a magnifier, as you can see in that visual there. And we can promote a healthy lifestyle to ensure that they can participate in their daily activities. Some examples of interventions for low vision include laptop and microwave use, so providing high contrast raised buttons. We could teach a person with central vision loss how to use another part of their retina to scan a medication label effectively. We could teach a person who has lost vision on one side of their body from a stroke how to scan the environment more quickly and completely on the blind side to avoid missing objects or an increase of falls. And we can work with the person to use prescribed optical devices such as handheld magnifiers to complete shopping, or a non-optical device such as a talking glucometer for a patient with diabetes. So this visual highlights some things that affect a patient with their independence and medication and pain management. There's various factors that could affect an individual's independence, such as their beliefs, forgetfulness, the cost of medications, the side effects of medications. So what can an OT do for medication and pain management? So when addressing medication management, we can provide education to the client and the caregivers on the medication itself, the side effects, and the safety hazards. This is particularly for patients that are having medications that might increase drowsiness or their increased risk of falls. We can assist with simplification of the medication routine. And then we can recommend or assist in retrieving visual aids or assistive devices such as pill boxes to increase their adherence to their medication program. In close relation, OTs assist with pain management. Pain can lead to disempowerment or a loss of control, which then will decrease their participation in activities. So OTs can provide educations to the patients and the caregivers on the diagnosis, as well as non-medical approaches such as strengthening programs. And lastly, OTs can assist in retraining a patient to manage the pain. We specialize in modality applications such as heat packs, cold packs, TENS unit, and ultrasound. We address a patient's body mechanics or the ergonomic setup. We can provide neuromuscular re-education and muscular tension reduction. And we are assisting them with proactive problem solving, pacing, and energy conservation techniques. The next topic of discussion is the OT's role in task modification. As mentioned earlier, we will complete an activity analysis, and after the activity analysis is complete and the deficits are determined, we want to see what can be changed about the given task to allow the patient more success. This might require restructuring the physical environment to assist occupational performance. It could require changing the technique used to perform the task, or it could require modifying and substituting objects used in the task to make it easier to complete. So some examples of this would be during household management. You can label cupboards and doors for a cognitively impaired patient, or you can remove a door for easier wheelchair access. For bathing, we could provide long-handled sponges or shower chairs and recommendations on the time of the day the patient should complete bathing. And for self-feeding, we could provide weighted utensils, universal cuffs, non-skid mats, plates, or bowls, and we could educate the patient on propping their elbows on the table in order to compensate for muscle weakness or even tremors. So here I included a picture of a project I have been working on with one of my patients in assisted living. This is a laptop I assisted my patient in purchasing. My patient has severe arthritis as well as low vision, and she has a desire to complete online banking independently. So the laptop that we purchased is equipped with a large screen, and then I went ahead and modified her icons and her text to be larger for increased visualization. And the computer is also a touch screen. So I assisted the patient with the stylus purchase. So on days where her hand arthritis pain is severe, she can use the stylus and the touch screen to use the computer. And then as you can see, I provided these yellow high contrast stickers to increase her visualization of the keyboard. The next topic we have is driving and community access. While many patients in assisted living facilities have forfeited their driving privileges, access to transportation is commonly something that my patients struggle with, especially those that have limited family support. So if a patient is deemed capable and safe to drive, an OT can assist with vehicle adaptations that are specific to their impairments. We could suggest aids or driving specific routes for increased safety. And we can simplify the process of helping the passenger in and out of the vehicle, managing their mobility devices, and demonstrating other ways to keep them safe and comfortable. If it's deemed that the patient is not safe to drive their own vehicle, OTs can provide access to public transportation, such as a bus system. We can assist the patient with the use of technology for transportation. So I've helped a patient order an Uber before. We provide services that are able to be delivered to the patients, so food delivery such as Instacart or utilizing Amazon for product delivery. And we also address the emotional aspects of driving retirement. So social participation and the role that OTs play is the next topic of discussion. Elderly activities with a social focus are crucial to a patient's overall wellness, especially for the maintenance of a meaningful and satisfying life. So without consistent social interaction, seniors can experience a variety of distressing conditions, such as debilitating loneliness, depression, and it actually increases the risk of dementia. So we foster increased social participation by providing education on the importance of it. We can provide visual aids to the patient for them to track their social engagement. We can provide education on specific social activities, and we can also assist the patient in technology use for remote social participation, something that's been very necessary with the COVID-19 pandemic. So as talked a lot, OTs provide a lot of education. We provide education to the patient, the family, as well as the staff. The education we provide might be attributed to their equipment use, the adaptations that would benefit them, or the recommendations that the OT is providing. But OTs also play a critical role in the importance of meaningful occupations for the individual. So an example I put here is a family member might feel it's unsafe for their mom, for example, to complete meal preparation on their own. And they might not recognize that that person completing meal preparation is imperative for their well-being. So an OT can provide education as well as adaptations to allow that mom or that family member to continue doing what's important to them, as well as providing it in a safe environment so the family feels comfortable. Next, we have the OT's role in wellness and health promotion. This is considered a preventative approach as we want to avoid deconditioning and illness. The health and well-being of a client is closely linked with their participation in personal occupations, particularly that of habits and routines. So we want to teach strategies to incorporate healthy routines. This intervention is specific to each client's needs, challenges, and strengths. So an example would be a client with diabetes. An OT can teach techniques to monitor their skin integrity and avoid skin breakdown, such as using a mirror to look at the bottom of their feet for pressure sores. We can assist in establishing a daily meal intake schedule for proper nutrition. We can address any barriers to meal planning and shopping for healthy food. We could create strategies for managing their food choices while at a social event. And we can assist with locating an accessible community exercise program or developing an individual home exercise program. Mental health is another component of a patient's well-being that an OT can assist with, and it's closely linked with health promotion. So in the absence of health, we see the effect of symptoms of illness on one's life and on their mental health. OTs can help to identify and implement healthy habits, rituals, and routines to promote and support a healthy lifestyle. We support the identification of personal values, needs, and goals to enable informed, realistic decision-making. We support the creation and use of a wellness recovery action plan or individual sessions. We provide information to increase their awareness of community-based resources. And we provide information on how to monitor their physical health concerns like diabetes management or smoking cessation, then develop strategies to control the chronic symptoms. We recognize and respond to the acute changes in their mental health status. This is in support of their engagement in long-term planning recovery goals. So OTs are often confused with speech therapists when it comes to cognition. While speech therapists play an imperative role in the cognitively impaired patient, OTs recognize the role that cognition plays in functional activity completion. So we'll assess everyday task performance and identify what performance-based impairments are affecting completion of their activity. So an example would be, does the person have the attention span necessary to complete meal preparation safely? Do they have the long-term memory that they need to remember the safety awareness information provided? And other functional components that we might look at include thought, temperament, and orientation. So to close, we have one of my favorite patients here, Dawn Palmer. Dawn and her daughter gave me permission to discuss some of the interventions that I have provided Dawn as I've been working with her the last several months. And also that's my really cute puppy, Theodore. So Dawn suffered a stroke back in 2018 and subsequently has some residual left-sided weakness or hemiparesis. Some interventions I have provided Dawn to address that residual weakness have been strengthening programs, weight-bearing activities, which is pushing weight through the affected limb. We've also done constraint-induced movement therapy, which entails removing the non-affected arm and forcing Dawn in a way to use her affected side. We've done a lot with her left arm positioning, as well as provided her with a lap tray. She was suffering a lot of skin tears to the affected arm, so now she uses a lap tray to keep it elevated. We've done passive range of motion, active range of motion with visual integration, as well as I've provided Dawn with visual aids. Through the tasks that Dawn and I have been doing together, she has regained some intermittent motion of the left arm. And I just wanted to share with you some of those numbers because we're really proud of them. She has gained 70 degrees of elbow flexion, 30 degrees of wrist flexion, 5 degrees of wrist extension, and she can also intermittently complete an active composite fist. So some interventions that I've done with Dawn to address her decreased posture and her need for assistance during transfers. We have worked a lot with core strengthening, such as completing bridging in bed. I've provided her and her daughter cushion recommendations to prevent her slouching in the wheelchair. We've done a lot of unsupported sitting, unsupported standing retraining, whether that be at a grab bar or at her sink. We trialed a transfer disc for Dawn to get in and out of her recliner chair. And I've also provided Dawn with a lot of education and trialing of different positioning for transfers, such as teaching her to transfer to the strong side. Some interventions we've done to address her decreased independence with her ADL routine is I've educated her on a dressing stick and reacher use, primarily to assist her with her lower body dressing. We've done left upper extremity inclusion during tasks. So Dawn used to sit at the sink and only wash her right hand because the left side was weak. And now she can independently go into her bathroom and wash both of her hands. I've also provided education to Dawn on hemi techniques, which is primarily used for dressing tasks. So here, I'm just going to show you guys a video of some of the motion we've gained back with Dawn's left arm.
Okay, open. Good. Close. And open. Good. Close. Close. All right, now bring it closer to your mouth. Good. Okay, hand it back to me. You always cheat at the end.
I love Dawn.
Okay,
She does always
open.
cheat at the end, though. Some other interventions I've provided Dawn have been to address her decreased leisure participation. She was having a lot of emotional concerns with her transferring to an assisted living from her home. So we have completed functional mobility in her wheelchair to outside areas, working on her propelling herself in the wheelchair. We've also worked a lot with positioning her wheelchair for her independent porch access. So we trialed her going out onto her porch, and I placed markers on the pavement so she knew where to position her wheelchair in order to come back in, as well as safety education for her doing that on her own. We've done left upper extremity integration during leisure tasks. We've increased her use of technology, such as her iPad. She now can watch her church service on her iPad independently. And we've increased her independence with financial management. If you know Dawn, you know she loves her bingo. So we've done a lot of fun things with her bingo money. Because of overusing her right upper extremity, Dawn developed a right upper extremity trigger finger. So I assisted Dawn with purchasing an ice pack and utilizing that ice pack to decrease the pain. I've also provided her with tendon massage and mobilization. We utilize an arthritic pain reliever to massage the tendon. And then I provided her and her daughter with splint recommendations. Throughout all of Dawn's interventions, I've tried my best to keep her daughter, her other family, as well as the staff members informed of interventions I'm providing. I put visual aids up in her room so that staff knows, hey, we're using the lap tray now in case I can't get to everybody in person. And that wraps it up for me today. I'd like to open the floor if you guys have any questions for me, and I appreciate you guys tuning in.
Please type them in the chat box if you have any questions for Caitlin. Oh, very informative, and Dawn looks great.
I love Dawn Palmer. What goes into an assessment and what is considered a risk? It's kind of a broad question. An assessment looks at a variety of things and it's very individualized for the patient. So it depends on what their diagnosis is. If I'm evaluating or assessing a stroke patient, for example, I'm going to look at their range of motion, the strength to the affected side, their cognition, their vision, their mobility. Are they able to transfer? Are they able to dress independently? And the risks is also something that's very broad and very dependent on the person. Fall risk is a big thing we look at, as well as safety hazards. Just depends on their cognitive state and what they're able to do on their own. As an OT, have you had any specific training in medication? In OT school, we do take courses related to medication, their side effects and their purposes. Outside of that, we have to do the continuing education classes to stay up to date on different medications, as well as which ones might affect different types of diagnoses. And thank you guys. Thank you, Cindy. Thank you, Sherlyn. I appreciate everybody tuning in. I hope it was educational. OT is kind of a really broad, fluid thing, so it's kind of hard to explain sometimes.